wait, otherwise we'll start just.
Doctors, they will join. Kindly wait.
Okay, so Dr. Bashar Raja will join. Dr. Bashar Raja has joined.
Good evening, sir.
Good evening, Dr. Basil Raja.
Good evening, madam. Good evening. Good evening.
Good evening, sir.
Good evening.
Good evening.
Good evening, sir. Good evening. Good evening. Good evening.
Okay,
So, Mihir,
so
can
I
we
think
start?
we can start. Yes, yes. Okay.
Yes.
So,
Sir, can we start,
very
Basab sir?
Yeah, you can go ahead. In another 2 minutes, I'll be there.
Okay.
You can go ahead
Okay.
with the introduction and all.
Okay.
Okay. So, very good evening to one and all. Wish you very colorful and happy Holi. And we are starting our first PG teaching module of this year 2024, that is Sandhya Pathsala, from today in the first time in the DIAP platform. And we have the galaxy of the dignitaries and the experts and the mentors who are very young pediatric cardiologists, very senior and the very renowned experts in the field of pediatric cardiology. And also we have joined the dignitaries from the Central IAP and as well as the West Bengal IAP. Now I will hand over to our President, Dr. Ashok Kumar, Professor Ashok Kumar Datta sir, to welcome all the dignitaries and experts and mentors. Over to you, sir.
Thank you, Mihir. So, this is our very good program. It started from the last year. It is the brainchild of Dr. Kalpana Datta, our president in 2023. This program is continuing till then, and today is the program is intended for PG students and doctors who like to learn the recent methods and other things. I welcome all the dignitaries for their participation and welcome all the students throughout India who are viewing this important discussion. I think it will give them a very important message and very important, interesting learning regarding the various aspects which are required during their postgraduate studies. With this introduction, I like to call Dr. Bashar Raja, our Honorable President, to say something about this Sandhya Pathsala conception and its importance for the PG. Welcome, sir.
Thank you, sir. Thank you very much. Thank you very much, Professor Ashok Kumar Datta, sir. Professor Ashok Kumar Datta, sir, is well known among the postgraduates as a great teacher, inspiration, mentor, motivator to the many postgraduates. Sir is at the helm of affairs. Along with our immediate president, Professor Kalpana Datta, madam, equally very popular among the postgraduate, and of course our Swapan Kumar Rai, and also happens to be our ACVAP member, our president-elect, and a very, very young and dynamic secretary of West Bengal Academy of Pediatrics, Mir Sarkar, and our first national treasurer of Indian Academy of Pediatrics, doing a great job at the national level. So what East can do it to the country. So Dr. Atanu Badra is showing his merits to the Indian at the national level of Academy of Pediatrics. And of course, today's program, which is something which is unique, which is well supported by the other team members like our Aswaji, Devendra Rai, Nilanjan Ghosh, and all others who has been really involved and today's postgraduate and mentor. It is always good to start with something creative and innovative. That's pediatric cardiology is something which is very much required for the present era, where previously we used to talk about an infection. Now the cardiological issues is coming up as a major thing. In that context, this today's topic is very, very relevant. I am sure this program is going to help the postgraduate student to learn and enhance their skill in the clinical practice. With these few words, once again, I wish you all the best for West Bengal Academy of Pediatrics for continuing in a PG teaching program with an innovative and creative mode of Sandhya Pathsala. Thank you very much inviting me here to say a few words on this occasion. And wish you all the best, West Bengal team of Academy of Pediatrics. I might have missed some of the names. I am joined through the mobile. Wish you all the best. Now our Honorary Secretary General Professor.
Sir, you're muted.
So wish you all the best.
Yeah, our Secretary General has joined, Professor Yogesh Parikh, sir. Ashok, sir.
यस बॉस आप बुलाया और हम आया
Thank you, sir.
Sir, Yogesh sir is there. I'd like to ask sir to speak something about this Sandhya Pathsala.
So our Honorary Secretary General, sir, few words before we start the academic session, sir.
yes sir so it will be the wonderful you are starting this Sandhya Pathsala by the West Bengal Academy of Pediatrics, and I remember while I was the president of Academy of Pediatrics Gujarat and we started the Gurukul Pathsala. It was very popular during the COVID, both the Saturday PG Pathsala and the Gurukul Pathsala on the Saturday and Sunday. So we hope Central IP on behalf of our team, President Sir, and you are also a part of the team, Dr. Atul Badraji. We wish best of luck and great success for this Sandhya Pathsala. And Down syndrome in your heart. We are seeing this. We are seeing this all this awareness of IIP की बात community के साथ, and our team working hard under leadership of our visionary president Dr. Basavaraja, and we have to reach to all the common people by the creating social awareness through the social media. So I request all of you to join on our mission of the IIP Baat community ke saath, along with this Sandhya Pathsala. Please convey this message on behalf of Central IIP for the each session. During each session in the last, please convey this message to the all people. Thank you very much.
Thank you, sir, both the Basub Raja sir and Yogesh Parikh sir, for allowing us to use the DIP platform for the first time for our PG teaching course. Thank you again, because within a few and promptly you responded to our email request and allowed us to use the DIP platform. Thank you from the WPAP to both of you. So now I think Dr. Subhasis Bhattacharya is there, sir, was the scientific chairperson. Subhasis sir, can you say a few words? Sir, you are muted.
Unmute, correct.
Sir, you are still muted, Subhasis sir.
I think there are some issues in the network. Continue whenever you can come.
Kalpana madam, are you there? Then it is the brainchild of Kalpana madam. We started the last year, so and now it is we are continuing it. So Kalpana madam, can you say a few words?
Okay, I'm traveling, so I didn't put on my video on. Very good evening to everyone, and thank you, Mihir, for giving me the opportunity. But I don't want to waste my time by saying words, because we have given only 1 hour time, or already 10 minutes gone. So only for 50 minutes there to discuss, because we need at least 2 hours time to discuss. So I'm not going to waste time. You start, all the best and good wishes. This is a very important clinical, I think, bedside clinics for everyone, for the postgraduate, for the residents, for the practicing pediatricians, and of course for the faculties also who are the teachers in the medical colleges. So this is very important program. I wish all of you a great success of this program, and request many students please join with this, and they will have a every, I think, alternate month, every month Mihir will highlight, and I
Every
wish a
month.
great success. Thank you.
Uh,
You start the clinics because I don't want to waste time. Already it is.
Mihir, can
Okay,
you
all
hear
the
me?
Yes, sir.
sir.
Just quickly,
Okay,
a few words.
welcome to all. And I think without wasting time, please start this first session of Sandhya Pathsala in this 2024. Okay, you start.
Okay, thank you, sir. Thank you, all the dignitaries and our president, sir, secretary, sir, and the West Bengal IIP team. So I will now hand over Dr. Nilanjan Ghosh and Dr. Rupa Bishwas, who was the main coordinator and the pillar of conducting or organizing this whole session. So over to you, Dr. Nilanjan Ghosh. You may just introduce the presenters, the mentors, and the experts, and start.
Good evening, everybody. Very quickly, today we'll be having two cases, and the presenters are Dr. Prithish Mondol, who is a second year PGT from RGKR Medical College, and Dr. Aditya Haldar, a third year PGT from National Medical College, Kolkata. We have two mentors, Dr. Shatanik Sarkar, pediatric cardiologist working at RGKR Medical College, and Dr. Malovika Maiti, cardiologist working at Medical College, Kolkata. We have two renowned experts, Dr. Devashri Gangobadhyay, who is a senior pediatric cardiology consultant at Rabindranath Tagore International Institute of Cardiac Sciences, Kolkata, and Dr. Amitabh Chattopadhyay, senior cardiology consultant at Narayana Hospital. So first, we have the case with Dr. Prithish Mondol. Prithvish, please start sharing your screen and start your case, and only 10 minutes, 10 to 12 minutes, no more than that. Very quickly you finish your case so we can have the discussion. That is very important. Okay, start.
Good evening, everyone, and wish you a happy Holi. I'm Dr. Pritish Mondal, going to present a case on pediatric cardiology. And my mentor for this case is Dr. Shatanik Sarkar, pediatric cardiologist and assistant professor of RGKR Medical College. Now I'm starting. As per the informant mother, the 4-year-old Hindu girl child from 24 Parganas presented with chip complaint for fever for 4 days and cough and running nose for the same duration. The fever, which was low grade, intermittent in nature, high grade and intermittent in nature, and maximum recorded temperature is 103 degree Fahrenheit, and fever is not associated with chill, rigors, subsided after taking antibiotics with little sweating. There is no particular history of evening rise of temperature, night sweating. There is associated with cough. The cough present and running nose. That cough present stayed for the whole days and night, and there is no particular aggravating or relieving factor, and there is no history of orthopnea or paroxysmal nocturnal disease. And in negative history, there is nothing significant negative history we have found in this case. In history of past illness and treatment history, the child was diagnosed with as ASD with PS at 10 days of age and underwent balloon valvoplasty of pulmonary artery at 1 year of age due to cyanosis, as I have found from past medical records. That saturation was 85% at that time in room air, and the child received furosemide for 1 month after balloon valvoplasty to prevent the failure. And moving on to next slide, birth history, we have found the patient, the mother in antenatal period, the mother was in regular checkups, and there are no complications like PIH or preeclampsia has been found. In natural history, the baby delivered 2.5 kg via LSCS. It was term. In postnatal history, I found that the baby cried immediately after birth, and there was no history of NICU stay after birth. Moving on to next slides. In other histories, we have found feeding history. The baby received exclusive breastfeeding for past 6 months, and now the baby is now on normal diet. An immunization history, we have found that baby received all the vaccines and immunization as per NIS guideline till the age. And developmental history, the baby achieved my developmental milestones as per age. Moving on to next slide. Family history. One elder sibling without any history of congenital heart disease and no history of consanguinity. Nothing significant history of allergy, and the baby belongs to middle lower class. In general examination, we have found the baby's child is alert, conscious, and oriented. Heart rate, pulse, it was 100 beats per minute, regular, normal volume, no delay, and palpable in all four legs. In blood pressure, we have found it is 96 by 50 millimeter of mercury in the right upper arm, 98 by 50 in left upper one, and 104 by 46 millimeter of mercury in left leg. Respiratory rate, it is slightly raised at 34 beats per minute, and accessory muscles are not working. Saturation, we have found that is 96% in the room air in all four limbs. Jugular venous pulse, it is found to be enlarged and 5 centimeter above sternal angle with prominent CV wave. Moving on to next slide, it is anthropometry. The weight of this child is 13 kg and expected it was 16 kg, and Z score is -2. Height of the child is 99 centimeter and expected it was 101 centimeter. Is almost normal, and mid upper arm circumference is 15 centimeter and expected it is 16 centimeter. Moving on to next slide, general examination. Hello, jaundice, cyanosis, edema, and lymph nodes. All was absent. Lymph nodes were palpable. Grade 2 clapping found in all four limbs, and the child is afebrile. Moving on to next slide, that is examination, systemic examination. First, cardiovascular system. On inspection, we have found precordium is slightly bulged. No visible pulsation. Visible pulsation is found at left border of the sternum. No scar or venous engorgement seen. In palpation, apex beat is found to be in left fifth intercostal space, 2.5 centimeter lateral to mid-clavicular line. It is diffuse in character, and thrill was absent. Base of the heart is no palpable. Palpation of the base of the heart, we have found it is no palpable P2 or thrill. In auscultation, we have found first heart sound is normal. Second heart sound is white and fixed beat, S2, A2 normal, and P2 soft. No third heart sound or fourth heart sound or any other additional sounds found. Murmurs, we have found soft ejection systolic murmur of grade 3/6 at left upper sternal border. It is high pitch, medium pitched, crescendo decrescendo. Character is soft. Conduction, no conduction is found. And pansystolic murmur were found in tricuspid area, that is 3/6. During systole, and intensity is medium, soft to growing in character, and increased during respiration. Respiratory system, we have found, I think heart shape and the size of the chest was normal. Slightly fast breathing with the respiratory rate 34 per minute, as I mentioned earlier. No chest indwelling has been found. In palpation, trachea is centrally positioned. Chest expansibility is normal. And percussion found resonant in all over the areas. And in the auscultation, we found the breath sound is vesicular and bilateral rhombi has been found. In GI tract, oral cavity and pharyngeal and tonsil gland, it was normal and tongue was moist. In abdomen,
Nitish, only the positive points and go on. There's no point in doing the in detail.
Don't do the GI tract, just get the main points in cardiovascular system and go to.
GI system, nothing significant found. Central nervous system was normal, no significant, nothing significant was there. And it is diagnosed as congenital cyanotic heart disease with decreased pulmonary flow, pulmonary stenosis, ASD with the post-balloon valvoplasty done in 2021. Now, it is found as a large ASD with left to right shunt and moderate pulmonary stenosis, severe tricuspid regurgitation, normal ventricular function, normal sinus breathing, no congestive heart failure or infective endocarditis, and nuclear heart association class 1, and intercurrent LRTI with wheeze. In moving on to next slide is investigations, and it is showing ECGs, and ECG shows this is sinus breathing with 100 rate is 100 beats per minute, showing a slight right axis deviation, mild RVH, and mild right-sided volume movement. Moving on to next slide, it is a chest X-ray of the child. It is showing PS with ASD. Here is some echocardiography that we have done in our setup. Is showing first, it is showing the fourth chamber view with the RARV dilated, and here it is showing AS large size ASD. Here it is showing tricuspid regurgitation, and this picture is showing tear gradient. Late. And this is showing SBC rings, that is absence SBC rings, and intact IVC. This is showing right and left ventricular functions. And final diagnosis is congenital cardiac heart disease with decreased pulmonary flow, pulmonary stenosis, ASD with post-balloon valvoplasty done in 2021. Now large ASD 20 millimeter, left to right shunt is there, and deficit posterior superior and SBC rings, moderate pulmonary stenosis with gradient of 56 millimeter of mercury, severe tricuspid regurgitation, normal ventricular function with normal sinus breathing, no congestive heart failure or infective endocarditis, and Newark Heart Association Class 1, and intercurrent LRTI with. Thank you.
Patanik, will you add anything to this?
So, Prithvish, one major thing you have missed in the presentation, like palpation, you have missed the parasternal area, the parasternal heave. Have not mentioned that.
Sir, this parasternal heave is found, and grade 2 with right left so parasternal area with grade 2 heave. I've missed it.
Okay, I think we have already crossed too much time, so let's open it for discussion.
Pritesh, Nilanjan.
Sir.
I asked 2 questions to Pritesh. How can you explain claving in this case? And you are telling palpable P2. At the same time, you are telling the S2 is normal and P2 is soft. S2 normal, A2 and P2 soft. At the same time, you are getting palpable P2. that is pulmonary third is present. You are telling the clubbing grade 2 is present there. How can we explain this clubbing? What is the cause of the clubbing? Is it familial clubbing? Have we examined the family?
Sir, can you repeat the question?
Huh?
Getting some difficulties.
How
This your voice is breaking, is not well audible.
Hello, it's not audible. Hello?
Your voice is audible. The Prithvi's
Sir,
voice is
your voice
breaking.
is clearly audible. Prithvi, can you hear?
Sir, I'm feeling getting some difficulties listening. Sir, some network issue is going on here. The rain is going on,
Did
and
you
I'm
hear what
feeling.
sir said? Did you hear what Dr. Ashok Kumar Datta said?
What I am telling you, you are telling clubbing is grade 2.
Yes, sir.
Palpable P2, that is pulmonary third. Palpable P2 term should not be used. It should be pulmonary third, THUD third.
P2 was not palpable, sir.
Did you mention the palpable P2 in your presentation? That's what sir saying.
No, sir, I have not mentioned it. P2 was not palpable, sir.
Fine.
You
What
have
sir is
mentioned. You
telling
have
you.
mentioned no palpable P2.
Yes, sir.
So these two things does not go hand in hand. What sir is mentioning is that palpable P2 plus you are saying that P2 is sore. I think there was a, I mean, you had just overlooked that one. I think it was a slip of tongue. That's what came in the flow. Sir, I think it was a slip of tongue. Is it? Because you are saying the P2 is soft, so in that case, the P2 won't be palpable. That's what sir is telling. Okay.
Okay, proceed further. Proceed.
Okay, so
Now-
Amita and Devoshi, if you have a question from the history starting, you can go back, Prithvish, to the history part, then the expert can ask or clarify anything.
Okay, sir.
Yeah, the next slide, please.
Sir.
Yeah, the whole thing is, the whole presentation, we have presented very well. First of all, congratulations. The only thing, some of the things which are not matching in the sense that I think Dr. Devashi would also agree that, first of all, as sir pointed out, ASD pulmonary stenosis. ASD pulmonary stenosis, though it can cause cyanosis, definitely, because if it's a large ASD, it can cause bidirectional shunt across the ASD, and there will be cyanosis causing clubbing. But at the same time, it's not very common to see ASDPS giving rise to cyanosis. That also grade 2 or grade 3 clubbing with rubbing of grade 2 and 3. That's one of the very uncommon things. Secondly, if if the ASD, there was severe pulmonary stenosis at one point, which was balloon dilated. That means it was a balanced circulation to begin with, ASDPS. Thereafter, what happened is their balloon dilatation was done. Most probably, the pulmonary stenosis was severe. That's why giving rise to cyanosis and clubbing. That's why the clinician thought that the balloon, at least the opening of the balloon pulmonary valve dilatation would help in increasing the QP. Because in your diagnosis, you have said this is a cyanotic congenital heart disease with decreased QP. The first line you have mentioned, isn't it? Usually ASDPS, yes, classically it can present pressure. Usually ASDPS is not classified as a cyanotic heart disease with decreased QP. It's a balanced category. Secondly, the no palpable P2 or thrill, that's fine. I think there was a slip of tongue, sir has mentioned. And also the clubbing. Can you explain the clubbing in this case? Why was clubbing there? Why was clubbing present? Was the bidirectional shunt across the ASD? Is the echocardiogram which you were showing, it shows a left to right shunt.
Can I show again?
No, I think there is another speaker is there, Nilanjan. Another speaker is there.
Yes, sir.
Time is short, another speaker is there. Only
No,
till
sir,
time.
actually we started 10 minutes late because the first day it can be a bit extended because the inauguration. So it can go up to 9:35 to 9:40, then we can start another case.
Okay, okay, go on. Proceed.
Sir, I think I want to clarify about the clubbing part. He won't be able to tell. So, first of all, the patient, as per history or the past medical records, he was probably having that severe PS with ASD. That was like a cyanotic heart disease.
Yeah,
With the PS was
that's right.
severe, which caused all the cyanosis and clubbing and all things in 1 year of age. Then the PS was relieved. That was valvular PS. So it was relieved, and now it is going like a ASD PS. Previously, it would have been a PS ASD, like a trilogy of Fallotype. So it
Mhm.
must have been for 1 year the child must be cyanosed and was having some clubbing and
Yeah, but the apex bit is in the left fifth space. It means there's some sort of a cardiomegaly. I mean, there was a mix, but I think there was a mixed kind of physiology. Apex bit in the left fifth ICS 2.5 centimeters. There is cardiomegaly, which a pathophysiology would see that the apex should be slightly upturned, or maybe there is some decreased pulmonary blood flow. Now you say that, as you are saying, it's probably correct that the ASD physiology is taking over, more predominant now. ASD physiology more prevalent now. But previously, the pulmonary stenosis was severe. That's why the pulmonary stenosis was relieved.
yeah, ASD must be shunting right to left mostly. So
Yeah, at
that's
that
why the
point of
clubbing and
time.
all things.
Yes, at that point of time. One more thing is the ASD. I mean, the BPD was done in 2021. At what
Yes,
age?
and at
Yeah,
1
at
year
what
age, I
age?
think.
Yeah, to get a clubbing at 1 year of age, slightly or clubbing of grade 2 and 3, unless it is a severely cyanotic. Thereafter, the patient has been behaving more like an ASD, but the clubbing is persistent. Till now, the clubbing is
One thing I would
persistent.
like to mention here is that tricuspid regurgitation, it was shown to be quite significant. Probably tricuspid regurgitation is adding to the amount of right to left shunt that is going across the
Exactly.
ASD.
Exactly. The TR flow is
Because
actually, the
we
TR
really do
is
not
directed
see significant clubbing in cases of ASDPS, that too at such a tender age.
that's the reason. The TR is directed towards the LA to the ASD. And there was some
That
problem
may
with the tricuspid valve also. Yes, yes. You are right. That the tricuspid valve, I think the tricuspid valve is also pathology. And that's why the TR is directed towards the LA. That's what happens in case of severe tricuspid regurgitation. It can happen.
One thing I would like to add to the X-ray. This X-ray was very beautiful. Dr. Pritish, can you please go to the X-ray slide?
Yes.
You said because at your level, it is important to understand what the X-ray shows, what chamber enlargement is there. Um, if you could describe what you understand from this chest X-ray.
Yes, ma'am. Please.
Can you tell me what are the chambers enlarged from this chest X-ray?
Very beautiful
Can you
X-ray,
tell me
Pritesh.
can you tell me is there a cardiomegaly?
Yes, ma'am. It is cardiomegaly is there. Sorry.
There's a very
And how do
beautiful
you take
findings,
care of
Pritesh.
cardiomegaly? Yeah.
Beautiful findings.
Because your case, you have already revealed the diagnosis ASGPS, but you should be able to tell a few differential, and your X-ray will help you in that. Just describe the X-ray maybe, because this is really a very nice X-ray.
You can begin with the pulmonary blood flow, whether it is increased or decreased. You can begin with the cardiomegaly. You are doing very fine, Pritesh. Congratulations. You are doing very fine. You can begin with that. There is a cardiomegaly, cardiothoracic ratio, pulmonary blood flow. You can begin with that one. For example, in this X-ray, I would say that there is cardiomegaly, definitely. Though you have mentioned that the cardiac apex is in the fifth space, but here there is a little bit upturned apex, like Shatanik also mentioned, it's like a Fallot's physiology type of thing. And there is right atrial enlargement because the right atrial enlargement is more than 3 intercostal spaces. This cardiac enlargement is most probably due to the ASD physiology plus the tricuspid regurgitation, both. there is upturned apex and there is decreased pulmonary blood flow. I would say, as someone, I think Dr. Rupa Vishwas mentioned, that there is decreased pulmonary blood flow. So the pulmonary stenosis component has become predominant once more. Again, the mixed physiology. You can see
So
it's
it is
kind of a
basically right atrial and right ventricular enlargement
yes,
with the reduced pulmonary flow.
pulmonary blood flow. So the apex beat probably won't be in the fixed space when might it's upturned, isn't it? They were straight. The apex is slightly upturned, at least on his X-ray.
Yes, yes.
It's bit upturned. But your other definitions, other descriptions are wrong. It is beautiful findings. Decreased pulmonary flow, right atrial enlargement with more than 3 intercostal spaces, and probably a RB tapetum apex, which is an upturned apex. But otherwise, your description has
Also,
been correct.
It is
is
expected.
X-ray
It is expected that in case of ASD, there will be right atrial enlargement will be there.
Yes, sir.
And it is expected. And also, bicuspid agitation is a very common finding associated with ASD. So that is also expected. In this case, that is severe. As the PS is severe, so there is no way bicuspid agitation is much more. But the circulation,
one of the
chest circulation to the lung is good enough. You cannot tell it as oligemic circulation, giving rise to cyanosis in this case. The apex is upturned, indicating the right ventricular hypertrophy in this case. So, which is normal findings in case of atrial septal defect. It cannot explain the cyanosis in this case, giving rise to carving other things. It may be totally theoretical. It is also unlikely that in the case of pulmonary stenosis, being PG, you should know. The pulmonary stenosis is giving rise to clubbing without any associated other things. It is very unlikely. Whatever may be the severity, in that case, the severe pulmonary stenosis gives rise to other problems. If it is critical pulmonary stenosis, it gives rise to other problems before giving rise to clubbing. Cyanosis gives rise to problems. So it is unexpected to find the clubbing. So there may be another explanation maybe there. Okay, I think we should not go beyond that echo and other things, ECGS, and we should go on clinically now.
Good efforts on Satanik and good efforts on Pritish. Well done.
Thank you. Well done, Pritish. Thank you, Shatanik. So next, I'll be calling upon Dr. Aditya Haldar, who's the third year PGT from National Medical College. He'll be presenting a case, and his mentor is Dr. Malavika Mai. Okay. So, Dr. Aditya Haldar, can you start sharing your screen, please?
Hello.
Aditya, can you start your video?
Sir, actually, there is a problem to starting. Sir, give me 2 minutes. I would start that, sir.
As sir was mentioning in the last case, that's in Pritish's case, tricuspid vegetation is an accompaniment, definitely, because more the right atrial dilatation and the right atrial right ventricular dilatation, the tricuspid annulus increases in size and gives rise to more PR. Plus, the addition of the pulmonary stenosis will increase RV pressures, giving rise to more PR. Plus, in this particular case, probably there was some amount of organic PR as well. We have to investigate. There was lysine giving rise to this. And Devashi mentioned the TRJ was directed towards the left atrium, giving rise to the more blue blood mixing with the red blood, giving rise to cyanosis and club. That was probably a nice explanation. Devashi, would you agree?
Yes, sir. Yes, sir, definitely.
Aditya, your screen is not, this is just blank white screen just. Can you hear?
Sir, just keep going. Sir, my PowerPoint is not opening actually, so I am converting this into PDF and then I'm sharing my screen.
Mihir, you can ask him to send the PowerPoint to you or someone else who can run.
Doctor, kindly send it to me.
Yes, ma'am, I'm sending it. Sir, is it visible? Hello?
Yes, it is visible. Aditya, go on.
Okay. Good evening, everyone, respected teachers. My name is Aditya Haldar, and now I am presenting my case, a complexity in heart. So, first, baby details are 7-month-old, second born to a consanguineous marriage, brought by mother from South 24 Parganas. Informant is mother. Next, presenting complaint was bluish discoloration of lips and tongue since 5 months of age. And next is failure to gain weight, adequate weight since birth. History of present illness, bluish discoloration of body. At 5 months of age, mother notices bluish discoloration of lips, tongue, oral mucosa, and fingertips. Appeared on crying and disappeared when the baby was calm and playful. One episode of increase in bluish discoloration and fast breathing, aggravated by crying and feeding, disappeared on flexion position. During episodes of increases cyanosis due to become breathlessness, but never used to have unconsciousness or seizure. Now, history of increasing redness of conjunctiva during that episode. Failure to gain weight. Mother also complained not gaining adequate weight in comparison to her another child since birth. Mother also no complaint of frequent loose stool, polyuria, or bony deformities. No history of puffiness of face and decreased urine output, fetal edema, and abdominal distension. No history of prolonged fever and hospitalization and painful fingertips. Has a history of recurrent episodes of cough and cold associated with low-grade fever. Now, his past history, he was admitted at 6 months of age for fever with respiratory distress. Treatment history, received frequent cough syrup and antibiotics from local doctors. Family history, nuclear family, no siblings. No history of tuberculosis, asthma, any congenital anomalies, or any congenital heart disease among family members. His socioeconomic status is upper lower class as per Kupuswamy scale. Birth history was antenatally within normal limit. No history of gestational diabetes mellitus. Second trimester anomaly scan and fetal echo not done. Natal normal vaginal delivery, 2.2 kg body weight. Right after birth, no essential admission. Postnatal breastfeeding started immediately. No history of cyanosis in early newborn period. Jaundice and seizure. Dietary history, he was on exclusive breastfeeding till 2 months age. After that, breastfeed along with supplementary top feed. Total calorie intake approximately 350 kilocalorie and 5 gram of protein intake. He was deficit in both calorie and protein intake. Development history, attained all age appropriate milestone. His gross motor was sit with support, fine motor transfer object hand to hand, social mirror play, and can identify strangers, danger. Language can utter monosyllable words. Immunization history up to date as per national immunization schedule, and review of system. He was has a increased respiratory rate and mild abdominal distension. Other system review was normal. Summary of history: a 7-month-old boy, second child of a non-consanguineous marriage. Cyanosis since 4 months of the age, with history of cyanotic spell in stress, while failure to gain adequate weight. My impression was this case might be a cyanotic congenital heart disease with cyanotic spell. Next, general physical examination. On general survey, cyanosis was present in lips, tongue, and fingertips, and grade 2 clubbing was present in upper limbs, fingertips, absent icterus, pallor, and edema. Her vitals was BP of 86 by 50 millimeter per Hg, equal in all 4 limbs, which is 50 to 98%. Pulse was 100 beats per minute, which is normal volume, regular. All peripheral pulses are palpable, and no radiofemoral or radioradial delay. Respiratory rate is 44 per minute, temperature within normal limit. Her SpO2 is 78% in room air and 80% with oxygen. Anthropometry, we have found that weight is 3.8 kg, that is less than third percentile. Height is 65, on which was on third percentile. Weight for height is less than third percentile. Head circumference 38 centimeter, that is less than third percentile. Mid upper arm circumference 10.5, that is less than third percentile. Upper segment, lower segment 1.2:1. Then on regional survey, we have found that bite or spot was present. Some eczematous lesions over dorsal surface. He had a Mongolian spot over back. Some pruritic lesion, likely scabies over abdomen, and some ectopustulosis was present. On systemic examination, on inspection, precodium bulge present, but it was a silent precodium. No JVP, no apical impulse was found. Palpation, apical impulses was felt at 4 meters costal space at mid-clavicular line in the left side. No palpable thrill, no parasternal heave was present. Trachea was in central positions. Percussions, nothing significant. And on auscultation, we have found that S1 is louder than S2 at mitral area, and a grade 3 high-pitched ejection systolic murmur is heard based with the diaphragm of the stethoscope in left parasternal region. No radiation. Tricuspid area S1 S2 heard, but pulmonary area we had a single S2. I think that and carotids are within normal limit. Other system, this PM CNS are within normal limit, but in GI system we have found that 3 centimeter liver is palpable below right costal margin, which was round in border, non-tender, soft surface. The summary of the cases: my 7-month old boy, second month to a non-conscious miscarriage with recurrent episode of respiratory infection and cyanosis since 4 months age, failure to gain adequate weight associated with digital clubbing, grade 2, and central cyanosis was present. There was an increased respiratory rate. On auscultation, we have found a grade 3 ejection systolic murmur, single S2 in pulmonary area. There is emission of trichotomegaly, no features of other system involvement, and any dysmorphism. My professional diagnosis: this is the case of cyanotic congenital heart disease with decreased pulmonary blood flow without complications of infective endocarditis, not in CCF, sinus rhythm, underweight, and immunized as per national immunization schedule. Likely or probable, this is the case of tetralogy of Fallot physiology. On diagnostic process, we have found that his ECG 12-lead electrocardiogram reveals a situs solitus, sinus rhythm, and a right axis deviation, probably due to right ventricular hypertrophy. The chest diagram reveals pulmonary oligemia and normal cardiothoracic pressure. Diagnostic process: transthoracic 2D echo. We have found that a complex congenital heart disease with large VSD and ASD, with straddling tricuspid valve, with hypoplastic right ventricle, pulmonary valve stenosis with patent ductus arteriosus. So final diagnosis was hypoplastic right ventricle, straddling tricuspid valve, pulmonary stenosis, PDA, large ASD, PST without infective endocarditis. I am trying to sketch the actual diagram. On management, we have general management. We have started furosemide and enalapril and referred the patient higher center for cardiac surgery. Some specific or surgical management for this child should be based on the degree of hypoplasia of tricuspid valve and right ventricle. Mainly the vena cava, mainly the superior vena cava to pulmonary artery shunt, that is Glenn shunt or Fontan procedure. And long-term prognosis, that is that OT needs, may raise the pulmonary diastolic pressure, which can lead to mitral regurgitation and left ventricular dysfunction. So our only function is ventricle, pumping ventricle. If impaired, then a risk for mortality. So close follow-up should be done. Thank you. Thank you for listening.
Thank you so much. That was wonderful presentation. And Dr. Malavika Maiti, would you like to say something for this?
Hi, good evening. Actually, two things doesn't match. One thing is frequent LRTI in a cyanotic child with decreased pulmonary blood flow. And second thing is his treatment. Furosemide and enalapril we generally give in increased pulmonary flow situation. If it is decreased pulmonary flow situation, we don't easily give this medication.
Okay, Milan. Nilanjan,
Yes, sir.
I like to Aditya, it is your very good presentation and it's nicely arranged, but few important questions are there. You have told in the beginning that cyanosis started from 5 months of age, and the second part in the summary you are telling, when history summary, cyanosis started from 4 months of age.
That was just a mistake.
This I think this you
It
should
should be
correct.
5 months ago.
So
Yes, sir.
this is one thing. Second important thing is that you have told the child is relieved by fixed position.
Yes, sir.
5 months old baby, fixed position means where is the flexion? So you can say that 5 months baby is relieved when the baby is taken by the mother's lap. That can give rise to flex position. Recurrent cough and cold can be explained in this case, as Malavika is telling that. The recurrent cough and cold in this case is expected because of the PTA present, giving rise to increased circulation here, that is the cause. Now, you have told the JBP not engorged. A 5 months old baby, or such a small baby, you are telling about the JBP. We do not require to mention JBP in a small child.
Okay, sir.
It can be. You have told in the last important history, the apical impulse is the fourth intercostal space on the mid-clavicular line. It is not the apical impulse. Terminology should be the cardiac impulse in the right, say left fourth space. Apical impulse, apex is always formed by the right ventricle. It is never the right ventricle which is forming the apex. Remember this. As a student, you should remember the apex is always formed by the left ventricle. So here you are doing, so you can say the cardiac impulse is the right ventricular type. You have told that there maybe this is the type where there is a increased pulmonary circulation. So pulse should be explained very nicely in this case. Pulse, regarding pulse volume and other things, equality of the pulse.
Sir, I think I have mentioned 4 points regarding pulse.
Pulse, you have to the normal, regular, all period pulse are palpable. You see, in a case of, in your case, the child is suffering from the recurrent cough and cold, it is increasing. It is indicating that pulmonary circulation is higher. There is more pulmonary circulation. Without that, there will be never cough and cold much more. And this pulmonary circulation is due to bypassing of the blood by the patent ductus arteriosus to the pulmonary artery because of the hypoplastic right ventricle. So this is the cause. So in that case, you see there must be some sort of say pulse volume and other things should be. Character of the pulse is important, which is not mentioned here in your pulse recording. And the other points which I think you should correct it. Next, go on for further discussion. Thank you for your good presentation.
Thank you, sir. Thank you very much.
Dr. Aditya, can I ask a question?
Yes, sir. Please.
Actually, nicely presented, but already Malavika has mentioned, but I want to note that also, that you have repeatedly mentioned the recurrent respiratory infection. So with the pulmonary stenosis, and you have also mentioned there's a lot of pulmonary oligemia, less amount of blood circulating to the lungs. So how do you explain this increased respiratory infection with the oligemic lung field in your particular this case? How will you explain that? Hello, hear me?
Sir, due to patent ductus arteriosus, mixing is there, so repeated infection can happen.
But your lung is oligemic.
Oligemic.
Probably,
I think this is a clinical case, bedside case. I think experts should explain for the benefit of other residents and all the residents.
Sir, one of the
Process might be
explanations
there,
can
but
be
I think the experts should explain the things and
as
some learning
one
points
of
for the residents.
yes, madam. One of the causes what Sir told is probably increased pulmonary blood flow is through the PDA or even the collaterals. Though these 7 months old presence of collaterals would be not much.
Dr.
One of the
Rupal,
causes is
please
that
ask the experts and mentors to Malavika and other experts to continue.
And the other explanation is most probably the child was not admitted any time due to LRI. No, probably it could
Viral
be
URTI.
Yes, it could be URTI only. Recurrent cough and cold, it could be URTI. So the child did not need any admissions. Probably it could be URTI, which is quite common.
Yeah, so that is the point. So the viral, they are not immune to like viral infections. They can happen with influenza, adenovirus, where happening in the community. They are attending the hospital, so can easily get the viral infection and upper respiratory infection. So they have the oligemic lung field. That's why they cannot have the respiratory infection. Is that they're immune to that? But they have normal risk of a general population, isn't
Yes.
it?
Yes.
Yes, and the child did not need any admission. Had it been an LRI, probably the child would have needed some admission or something. And in all probabilities, all these LRI, I mean the URIs were treated at home. Most probably.
No, Aditya, you show me the
Yes, sir.
history. In the history, at 6 months of age, the child was admitted. I think in the history, last part of the history.
Yes, sir. One admission, sir.
6 months of age for fever with respiratory distress. So,
Yes, sir.
so you see, there is
one admission.
Clinically, if you think that it may be your history, maybe due to this, say, circulatory changes in the lungs. I don't know what is the X-ray. X-ray showing the pulmonary oligemia, no doubt. And but clinically, as there is PDA is present, there is, and say after 6 months the admissions there. So remember, in a case of say pulmonary oligemia, it is never chest is infected. This concept is not correct.
Yes,
so
sir. Absolutely.
May be
Yes,
there.
sir.
Infection may be there because of the several important things. As the baby is suffering from the hypoxemia for the long time, the resistance is decreased, the macrophage actions are decreased, the mobility of the cells for attacking the infective organism, that is also decreased. So there are chances of infection definitely in the lungs also in case of oligemic lung also. But as Amitav and me says, the upper respiratory infection, Malavik also said, upper respiratory infection may be there. But remember, it may be, you can counter this, but there are chances of infection because of the low immunity of these children. Okay.
Yes, sir. And another important thing is that their immunity, with these patients are having the high hemoglobin level, also the ferritin level may be high. So ferritin can act like a dual way. So it can be a pro-inflammatory and also that leads to hyperinflammatory reaction as well. So that may be the another cause.
Dr. Ravi, I would like to ask a question.
Yes, ma'am.
Yeah, very nicely you have presented your case. Can you comment on the status of the liver? Do you think there was a hepatomegaly? You said liver is palpable 3 centimeter below left costal margin. Is that a hepatomegaly?
Ma'am, 7-month-old child more than, up to 3 centimeter, it's mild hepatomegaly.
Why do you think there could be?
Aditya, you should measure the liver span. You should say
yes,
the liver span.
Yes.
How
Liver
much?
span.
What is the liver span in this case? And depending on that, you should say whether it is hepatomegaly or not. It is not the palpation of the liver below the costal margin. This should not be. What was the liver span? Span of the liver is important.
Sir, I missed to measure the liver span.
As postgraduate, I advise you always measure the liver span, and then you measure what is normal, and then say whether there is hepatomegaly or not. Okay.
Yes, sir.
Yes,
sir.
Yes, because hepatomegaly in a cyanotic heart disease is not easily explained, especially when you are saying that there is no sign of congestive heart failure.
Yes.
Do you expect any other causes? Any other causes you are thinking of? Any other causes coming into your mind, Aditya?
Sir, I think it's a cyanotic congenital heart disease, but in later, sir have mentioned that circulatory changes happens, and sir, that PDA may cause a large amount of shunting from systemic circulation to pulmonary circulation. That's why the child has that infection and may go to into CCF, and sir, that's why liver may become.
Aditya, you're deviating from your findings. You're deviating from your own findings because your X-ray shows clear polygemia. So if PDA cannot be very hemodynamically significant. PDA may be there.
Yes.
It's a small duct, but it cannot give rise to significant left to right shunt. And also, your history is also pointing against having a sizable PDA because there is history of cyanotic cell. A baby who is having a significant amount of extra pulmonary flow will not go into cyanotic cell. Should not.
Yes.
So PDA, even if it is there, it's an echocardiographic finding, but it's not having any hemodynamic effect in this particular cell.
Yeah, Dr. Devaship, in this case, we can say if there's a significant hemodynamically significant blood flow in the lung, in a phallus, we say pink phallus. There shouldn't be cyanosis also.
Yeah.
As you said.
In a case, what I'd like to add with Dr. Devoshi and Kalpana, being PG, you should remember, this is one PDA dependent, ductus dependent disease. There are few diseases that ductus dependent, and this is hypoplastic right heart.
Yes.
The ductus dependent disease. Remember this. If the ductus is not there, the lung will not get blood supply. And that also depends on what is the degree of the hypoplasia of the right heart. So it is ductus dependent disease. It may be that it may not overload the lung, but the child is surviving up to the age of 7 months in a case of right-sided this problem, hypoplastic sleep. It means that it is surviving by circulation from the other sources. And what is the source? Who will give supply to the pulmonary artery? Except PDA. So PDA is giving supply to the pulmonary artery. I don't know about the X-ray findings which you have got showing the polygemia, only that, except that other things in the clinics, related to the clinics, the explanation is there. Okay.
As Dr. Devashi was pointing out, if you are saying a cardiomegaly in a case of cyanotic heart disease, that means the RV is not pumping enough, or that there is RV failure. That can be one of the possibilities. Okay? That's what she was pointing out. But it is very unlikely at the age of 7 months. It is very unlikely. In all probabilities, in your case, what might have happened is, as Sir pointed out, you should have the liver span. That means probably, in all probabilities, there was hyperinflation of the lungs. Because the child already had some LRI and was suffering from respiratory illness, there might have been hyperexpansion of the lungs. That's why the liver was slightly pushed down.
Simply pushed down liver, yes.
Yeah, it was liver is slightly pushed down. But your finding was correct. The explanation might be this thing. Otherwise, if the liver is palpable, that means there might be RV failure, which is a very late feature. Usually, it's a late feature in tetralogy or any scientific artery. It's a very late feature when the RV right ventricle starts failing.
Yes.
Otherwise, your presentation is very good. Any comments on the X-ray? Can you show me us the X-ray? There's plenty of things to learn from the X-ray. Your X-ray is quite interesting. Very interesting X-ray. Yes, the X-ray. You can focus on that one. Yes. Would you like to describe the X-ray?
Sir, trachea in midline positions, bilateral lung field are visible. So there is prominent pancovascular margin up to 1/3 of the lung field. So I can comment that it is a pulmonary oligomia. And sir, cardiothoracic ratio is is like normal to me, but there is a bulge in right side of the heart, likely due to right ventricular hypertrophy.
No, your
Okay.
X-ray is not clear at all. Very difficult to understand the X-ray.
Awesome.
X-ray should be clear cut.
One thing is clear that there is upturned effect. That
Yes.
thing is standing out from the ischemic lung field and upturned effect.
It's an upturned apex. It's a totally upturned apex. And also the pulmonary bay is slightly concave, which implies that the pulmonary artery is slightly smaller in size, or even in some cases of pulmonary atresia, it can be totally concave. In this case also, your pulmonary bay is not full. That means it is slightly concave. That means decreased pulmonary blood flow is being supported by this finding. RV apex and is upturned. Pulmonary oligemia. We would have liked to comment on the tracheal indentation, but it is not clear from your X-ray. Because sometimes in about 25% of cases, tracheal might be associated with the right-sided aortic pouch, but here it is not clearly visible. And ECG has very interesting findings as well. There is right ventricular hypertrophy, but half of the ECG is cut away. Most probably is right axis deviation, right ventricular hypertrophy, with evidence of RV stream. With evidence of RV stream. That's what. Devashri, any comments on this one?
I say the half of it is cut off, but yes, what you said, I agree to that.
Yeah, right axis deviation, sinus rhythm. There is right ventricular hypertrophy.
Right ventricular hypertrophy, yes.
Yeah, the classical finding of tetralogy is
The
early
previous
transition.
the previous ECG had a very beautiful example of right atrial enlargement, which is absent here.
Yes. Yes, exactly. The previous, there is Prithish's ECG. I mean, the Prithish's case ECG.
Prithish's case ECG, yes.
How will you explain the right ventricular hypertrophy? You are telling the hypoplastic right heart syndrome. At the same time, you have right ventricular hypertrophy. Actually, X-ray, your view should be very clear cut. This view is not good at all. We are, except expert like Amitav and others, we are facing difficulty in viewing the X-ray.
Yes, sir. The X-ray is not, it's not clear. Definitely.
X-ray also ECG. There's a blood. I don't know why. It is
very difficult to understand.
I think
type of presentation, it should be clear cut. Okay. So how can we explain in a case of, say, hypoplastic right heart, you are telling at the same time the apex is upturned, apex, that is left ventricle is pushed to the back and left and posterior. How can we explain that, this upturned apex in this case?
Sir, right ventricular hypertrophy, maybe sir due to
you are telling the
concentric
hypoplastic right heart syndrome. There is all the right side, right ventricle, all these things are hypoplastic.
Yes, sir.
Okay. So if there is hypoplasia is there, then who is pushing the left ventricle to this position? So this is the important.
Very nice question.
This your X-ray plates should be clear cut projected. It's very easy to interpret and all.
You said that a duct is present, no? Duct is present. And was there any forward flow through the pulmonary artery? Aditya, was there on the echocardiogram, was there any forward flow? Or was it pulmonary stenosis or pulmonary atresia?
Yes, sir, pulmonary stenosis, sir. Pulmonary stenosis.
Okay.
Sir, it is 10:10 now. I think we can end after, because I have given the 1 hour allotted time. So it is already 10:10. So we can just give one final comments from the expert and the mentors, and then we can end up.
So one thing just I like to add to Aditya. Here is your experience of this right ventricle. In spite of the right sided, say, heart disease, say hypoplastic right ventricle. Remember, in that case, the right ventricle activity to some extent may be done by the large VSD. Large VSD is important here. Okay. The circulation to from the left side will go to the right side to the large BSD, that can give rise to some important things. And there is also startling of the tricuspid valve that can also raise some pressure in the right ventricle. So right ventricular blood pressure and other things are increased, which is normally not expected in case of hypoplastic right ventricle.
Yes, sir.
Amitav, please give the final conclusion to this.
Yes, sir. And the right ventricular as on the ECG. Can you get Aditya? Can once more? Can you get the ECG, please? This is possible in the case for example, your VSD was large and actually in actuality the disease you are describing. Your ECG is showing the V1, V2, V3, V4 having almost similar complexes as well as V5. The only explanation can be this was most possibly behaving as is physiologically like a single ventricle situation where the right ventricle small does not matter anymore. It was basically a left ventricle, single ventricle of left ventricular type. And that is you are having monomorphic type of ECG pattern in the first 5 leads. There is including V1 to V5. That can be one of the possibilities.
Correct.
Otherwise, that might be one of the possibilities which sir is telling. Otherwise, the explanation what sir is telling is, for example, say there is tricuspid atresia. In those cases also, there might be right axis deviation or even superior axis, but the right ventricular hypertrophy won't be very much prominent as is prominent in this particular case of yours. So that's what there is a controversy, but probably you can name it as probably on echocardiogram, on a very finer echocardiogram, you can say that it is as single ventricle because the right ventricle is already small as you have shown in your figure. There was a figure which you have drawn figure that right ventricle is already small and there is basically a single ventricular type which is behaving like a single ventricle. That can be one of the possible explanations. In this figure, you have shown that it is basically a single ventricle type. That means the right ventricle is very, very small. Isn't it?
Yes.
Or else there might be what your initial explanation was that there's severe muscular hypertrophy of the right ventricle, which is possible if there is a pulmonary atresia with almost intact interventricular septum. But in this case, you have a VSD. So that explanation does not come. Most probably it is behaving like a single ventricle type of a situation. That may be one of the explanations why you are getting almost similar QRS patterns in lead V1 to V5 almost. Devashri, any other explanations you were having?
No, I think yeah, that is the only probable explanation because the QRS morphology is monomorphic.
Yes.
And
Now
but it
V1
is
to V5.
but there is on ECG it looks that the RV is dominant over LV because on lead V6 also their waves are prominent compared to the R. So their RV will be hypertrophied muscle bound and there must be a large interventricular communication.
That's one of them. It's behaving physiologically, is behaving like a single ventricle type of activity. Most probably that is the
And also because the RV, even though it's Aditya says it's hypoplastic, but the reason for this upturned apex is the heart has assumed a horizontal position.
Yes.
Because of this abnormal RV shape and RV muscularity. Yes. So that is the reason because this X-ray looks very classically like tetralogy of fallow chest X-ray. I don't know.
Exactly.
Like if this echo finding was not there, I would have passed this case as a tetralogy of fallow with cyanotic pelts and everything.
Exactly. Most probably there is muscular hypertrophy of the right ventricle. That's why the ECG pattern is like this. Most probably that's the situation. But anyway, there is a very beautiful question, sir, what you have asked, because it is rightly noted that there is right ventricular hypertrophy, but the RV is shown to be quite small in the figure. And well presented.
Without the echo, we would have called it a case of classic tetralogy of fallow.
Agreed.
Thank you so much.
Can I say something?
Okay.
Actually, I think we should discuss up to I'd like to say that we should give more importance to the clinical diagnosis because in the exam we are not going to have X-ray, ECG, and echo. So how to approach the diagnosis is very important, huh?
Yeah, next time it's better not to include the echo images and also for the
That is
presenters
for the
not to
management
know
point
about
of
the
view.
exact diagnosis, because that's not the
Yes.
point to get the exact diagnosis. Point is to
Yeah.
discuss.
How to approach. Yeah. Yeah.
Yes, ma'am.
All the
Exactly.
findings to be explained clinically.
Exactly. And both of the presenters have presented very well. And
Very nice
basically,
presentation.
nice presentations. Thank you, Malubika and Shatani, the two mentors. You have guided them very well. And the two presenters as well. You have presented very well. Thank you, sir. And thank you, Mihir, and all the
Thank
IIT
you, sir.
graduates. Thank you, everyone. Thank you, everyone.
Thank you all dignitaries and other things.
Thank you all for the experts and the mentors and the presenters that presented really well and very engaging and interactive discussion at the end. Thank you all the experts. I will now before ending, invite our national treasurer and our own Dr. Nuda to say a few words, and then I will request Nilanjana to conclude.
And
Thank
Dr.
you.
Mihir, please,
Yeah.
please meet the next date of Pathsala.
Date will be same 25th of every month. We'll do the every 25th of every month.
Okay.
Okay, thank you.
Sorry, Dr. Tanha,
Yeah.
for interview. Sorry,
No,
sorry.
no. Thank you, our experts, Dr. Malubika and Dr. Devasri, Dr. Shatanik, and of course, Amitavo. His expert comments made it very lucid to us for non-cardiac persons like us, but it was really interesting. And I thank every one of the delegates and everyone who joined on a day of celebration of Holi, giving out time for academics. It just shows how committed all of you are. And I hope the CIP had only one program today where it was done on Holi. So West Bengal shows the way in academics. And thank you. We'll meet in other programs in other platforms. And I think every one of us should come forward to not only participate in academics, but as our president had said, to participate in community work also. So whatever help WBAP and CIP can do, will be there with you. Please design your community programs. On 2nd of next month, we'll be starting our program on autism. Thank you, and again, happy Holi to all.
With that, we come to the end of today's Sandhya Pathsala, and we'll be preparing for the next one. Hope next one will be another excellent Sandhya Pathsala. Thank you all. Good night.
Thank you. Thank you.
Thank you. Nilanjan did a great
Happy
work.
Holi to all.
Nilanjan and
Thank you.
Rupa.
Thank you, Atananda. Thank you.
Thank you, and good night.
Thank you, Dr.
Good night. Good night.
Thank you, Dr. Thank you, Dr. Nilanjan.
Good night.
Thank you.
Thank you. Good night.
Good night.
Good night.